All right. Good morning, everyone. My name is Caitlin Goggin, and I am the CEO with the Canadian Partnership for Women and Children's Health, CanWaCH. We've got a 9 a.m. start here in at least our time zone, and it's just 4 past the hour. So we'll get started. Good morning again to everyone. On behalf of the Canadian Partnership for Women and Children's Health, it's my pleasure to welcome you to today's session. Access to health, strengthening transparency, accountability, and inclusion in service delivery. Access to quality health services is foundational to advancing gender equality and sustainable development. Yet, as we know, corruption and discrimination continue to shape who benefits from public systems and who is left behind. Today's conversation will bring us closer to practical, operationally informed approaches which strengthen transparency, accountability, and inclusion in service delivery. Before we dive into the rest of the program, I have some quick but important housekeeping. Aspects of today's discussion will be presented in both English and French, and we are therefore pleased to offer simultaneous interpretation for this meeting. To access this tool, simply click on the global button located in your Zoom toolbar and select the language you would like to hear. To hear translated audio only, click Mute Original Audio. Instructions have been posted in the chat in case I haven't made any of that clear. To have the best viewing experience, we suggest that you switch your settings to speaker view. To do this, navigate to the top right corner of your Zoom screen and toggle the view button from gallery to speaker view. If you're having any trouble at all, my colleagues Deborah Dehan and Tina La Rochelle are in the chat for assistance. Now, it's my honor to hand things over to Salvatore Cusimano, Executive Director for Transparency International Canada. Over to you, Salvatore.
Thank you, Caitlin. We're really glad to be able to present this event in partnership with CanWaCH, and we're extremely gratified by the participation today. I will speak in French and in English, so if you do require translation, please again, just make sure you toggle to that translation button. If not, use it as an opportunity to test whichever language you don't speak as well. Alors, nous sommes ici aujourd'hui pour discuter du projet Inclusive Service Delivery in Africa. C'est un projet qui a été fondé par Affaires mondiales Canada pendant 4 ans. Et c'est une partie importante de notre travail ici au Canada. C'est un projet que nous mettons en œuvre avec 5 sections de pays de Transparency International en Afrique et avec nos collègues au Royaume-Uni. C'est-à-dire que Transparency International, pour vous qui n'êtes pas familier ou ne connaissez pas notre organisme, nous sommes un organisme global avec une centaine de sections au niveau de différents pays un peu partout au monde, et nous sommes la section canadienne. Et nous avons 4 priorités stratégiques au Canada. Le premier, c'est mettre fin au flux d'argent sale ou au flux d'argent illicite, le blanchiment d'argent. Le deuxième, c'est de promouvoir l'intégrité dans le secteur privé, dans le secteur des affaires. Troisième, il y a de promouvoir l'intégrité dans la politique canadienne. Et quatrièmement, de protéger les ressources du grand public. Alors, we have to ask now a very important question before we have this discussion. It's essential to understanding the terms of this discussion. What is corruption? It's a word that we hear often, but that I think is seldom defined. And in Transparency International, when we talk about corruption, we're talking about the abuse of entrusted power for private gain. Again, there's 2 very important parts to this definition. The abuse of power, a power that's entrusted usually by the people, for private gain. That's the second part, the private gain. And this can take many forms, some of which we're very familiar with, and others that we don't hear about as much. You can have public servants demanding or taking money in exchange for services, politicians misusing money or granting jobs or contracts to friends, corporations engaging in bribes to get more lucrative deals. And then on an individual level, people having to pay bribes to get access to services. Tout ça est plus ou moins bien connu. Mais le mot corruption est toujours sensible, est souvent sensible et c'est toujours politique. C'est parfois utilisé comme arme, comme prétexte contre les opposants politiques. Et nous l'avons vu aussi utilisé comme prétexte pour justifier les interventions militaires à l'extérieur. And in the world of international development and global health, we also see that it's sensitive. We also see that it is always political, and perhaps even more accentuated in the world of global health. We also see that it resonates with notes of neocolonialism at times. It is used as a pretext to deny foreign humanitarian or development assistance. It's used in a way that can reinforce stereotypes, racist stereotypes and tropes, and it can gloss over important cultural and social norms that speak to the different lived realities of people who are seeking to have their basic needs met around the world. But herein lies a challenge: is what do we do when we know in the field that we work in that public service delivery can be affected by the abuse of power for private gain. Now, this project has been extremely important for us because I think it's shown that far from pulling back, far from justifying disengagement, this project has shown us the need for a renewed commitment to global health and global education, as you'll learn in another webinar, but perhaps on terms more sensitive to social norms and the way social norms shape governance in many of the countries we work in Canada as well, and the way it shapes the lived experience of communities seeking access to social services, particularly marginalized populations. And in this case, we took a close look at the way women and girls in particular are affected. Aujourd'hui, je pense que vous allez voir au moins trois choses qui vont éclaircir le problématique qui est devant nous et qui était devant nous dans ce projet. Premièrement, nous avons appris que le Canada n'est pas à l'abri. Les enjeux que nous avons constatés avec nos sections africaines dans leur contexte sont bien évidents ici au Canada. Et loin de penser de la corruption comme quelque chose qui se passe ailleurs, nous avons pu réfléchir au fait que la corruption est quelque chose qui se passe ici et qui se manifeste même dans des formes et des manières qui sont relevantes ici au Canada. Second, we can understand better how corruption operates and what its many human costs are when we apply a gender-sensitive lens to how it exists in public service delivery. And you'll hear that today. And finally, we wanted to say that we're very happy this event is able to happen around International Women's Day because it gets to the way that governance shapes women and girls' access to social services at individual community level, at institutional level. And then we will have a structural level reflection throughout today's conversation. And even the fact that we're here having this in Canada, it's a worthwhile opportunity to think about how do we transform the way we do international assistance to be more equitable, to shed its neocolonial tropes and to really try to deliver value for people on the ground and to say we still need to do this. Alors, avec tout ça, j'ai le plaisir de vous présenter Gérald Prouveau Anandrea Jamana, qui est officier de projet de santé au Madagascar, dans notre section de Madagascar. Nous sommes très contents de l'avoir avec lui et merci d'être là parmi nous en dépit du décalage d'heure. Merci Gérald et à vous.
Oui, merci beaucoup, Salvatore. Est-ce que vous m'entendez bien?
Très bien.
D'accord. Bonsoir à tout le monde et bonjour à certaines personnes qui sont dans d'autres décalages horaires parce que Madagascar ici, c'est presque, on est presque dans la soirée. Donc, je m'appelle Gérald Pruvot. Je suis le chargé de projet pour Transparency International Et actuellement, je conduis un projet qui s'appelle Inclusive Service Delivery Africa. Donc, pour ma présentation, je vais vous partager un peu ce que nous faisons. C'est quoi le projet, le programme ISDA et qu'est-ce que Transparency Madagascar fait exactement dans ce projet. Donc, le projet ISDA, c'est un programme qui est soutenu par Global Affairs Canada et en collaboration étroite avec TI Secretary et aussi TI Canada qui sont des appuis techniques dans ce programme. C'est une initiative quadriennale qui est déployée dans 5 pays africains, dont Madagascar, comme on l'a dit tout à l'heure. Le projet se concentre sur trois défis majeurs, qui est l'accès aux services, sur un défi majeur, excusez-moi, l'accès aux services de santé et d'éducation. Mais pour ma part, je vais plus parler du secteur de l'éducation. Donc, l'objectif principal du projet pour le secteur éducation, c'est vraiment d'améliorer l'accès aux soins de santé primaire pour tous. Et nous mettons plus l'accent sur les femmes, les filles et les groupes vulnérables, comme les personnes vivant avec, qui sont en situation de handicap, les personnes âgées et les enfants de moins de 5 ans. Donc, nous partons du principe que la corruption n'est pas un problème financier, mais peut être considérée comme un obstacle structurel qui aggrave les inégalités sociales. Donc, le programme ISTA vise à transformer ce système en travaillant sur 3 piliers principaux qui sont la performance des institutions, l'engagement des citoyens et aussi le changement à travers le changement des normes sociales et aussi de genre. Donc, comme vous le savez, ce projet évolue dans un contexte inchangé pour Madagascar, parce que Madagascar, depuis des décennies, vit toujours dans le même contexte avec des instabilités politiques récurrentes, le manque de ressources avec un budget destiné à la santé avoisinant les 5% du budget général de l'État, et ce qui signifie moins d'investissement pour le secteur de la santé. Et aussi, pour ajouter à cela, il y a beaucoup de zones géographiques qui rendent les centres de santé de base inaccessibles et aussi enclavés. Euh, donc, qu'est-ce que nous faisons actuellement? Quelles activités nous avons déjà mis en œuvre et où en sommes-nous actuellement? Je tiens juste à préciser que Madagascar a 4 moyens d'action principales qui sont les recherches-actions, la mobilisation citoyenne et communautaire, les journalismes d'investigation, où nous travaillons étroitement avec un réseau de journalistes, et aussi nous faisons des campagnes de plaidoyer auprès des décideurs et du ministère de la Santé. Donc, si vous pouvez passer au slide suivant. Merci beaucoup. Donc, quand je dis, nous évoluons dans 4 actions principales. Donc, pour la recherche à action, TIE Madagascar a mené 3 études durant ces 4 années. Le premier, c'était le Corruption Risk Assessment, où nous avons mené une étude approfondie dans les centres de santé de base qui sont les plus près de la population en termes de pyramide. Donc, ce rapport a identifié les points critiques où la corruption a le plus d'impact ou a la plus grande probabilité d'apparaître dans ces centres de santé. Donc, dans ce rapport, nous avons mis en exergue 2 services principaux qui ont un haut risque de corruption, qui est la gestion des stocks de médicaments, qui suscite actuellement un grand débat et constitue un énorme barrière pour les usagers de ces centres de santé, et aussi l'existence des paiements informels, surtout pour les services d'accouchement, euh, qui, je pense, aggrave plus la mortalité maternelle actuellement. En second lieu, nous avons mené aussi une étude sur le lien entre la corruption et la discrimination. Donc, après avoir évalué ces risques de corruption, nous avons vu que la corruption à Madagascar peut engendrer plusieurs formes de discrimination. Donc, cette étude nous a permis d'évaluer en fait les intersections entre la corruption et la discrimination dans l'accès aux soins de santé pour les femmes, plutôt un focus dans les maternités, Donc, nous avons pu identifier les barrières multidimensionnelles qui peuvent être géographiques, financières et aussi systémiques, qui rendent les femmes plus vulnérables. Durant l'accouchement, il existe des frais illégaux qui sont demandés par les centres de santé de base, surtout par les personnels de santé euh, qui mettent en œuvre ce service d'accouchement, en fait. Donc, je tiens à préciser qu'à Madagascar, il existe des exemptions de frais pour les services de maternité, sauf en cas de complications, bien sûr, où les patients doivent être référés à un hôpital public. Donc, ce type de frais est déjà considéré comme de la corruption et cela va créer plusieurs formes de discrimination et d'inégalité de traitement parmi les usagers. Donc, on peut voir la discrimination économique, les barrières systémiques où les personnels de santé confisquent les cartes d'identité nationale des femmes qui n'arrivent pas à payer ces frais informels. Et il y a aussi les inégalités de traitement dans la priorisation des soins qui sont basés sur l'apparence sociale et ou les relations des personnels. Et un point aussi pivot dans ce projet, c'est l'étude sur les normes sociales et les normes de genre. Donc, cette étude a été mise en œuvre en collaboration directe avec BESA Global, qui est un appui technique important dans ce projet. Donc, dans cette étude, nous avons analysé comment certains comportements, par exemple les cadeaux de gratitude, qui se transforment parfois en pression corruptrice et comment ces normes maintiennent les femmes dans le silence. L'objectif est vraiment de démontrer que la corruption dans la santé à Madagascar n'est pas seulement un problème de manque de ressources, mais qu'elle est socialement normalisée et structurellement rationalisée. Et puis, nous travaillons aussi dans la mobilisation citoyenne et communautaire où nous faisons des sensibilisations, nous menons des campagnes de sensibilisation auprès de la communauté, où nous enseignons le droit à la santé, nous essayons de les conscientiser sur l'importance de connaître ce droit en matière d'accès aux soins. Nous travaillons aussi étroitement avec les personnels de santé, où nous construisons le dialogue et essayons de apporter la voix de cette communauté auprès des responsables pour comprendre en fait quels sont leurs problèmes, quels problèmes ils vivent dans la communauté qui les empêchent vraiment d'avoir accès à ces centres de santé de base pour les usagers et aussi qui conduisent les personnels de santé à vraiment à demander en fait ce type de frais informels. Nous travaillons également avec les organisations de la société civile à Madagascar qui sont implantées partout dans diverses provinces. Nous travaillons avec eux en mettant au pied en fait une coalition qui va conduire les plaidoyers sur les réformes possibles du système de santé à Madagascar pour que l'accès aux soins soit vraiment pour tous et qui soit de qualité et aussi qui peuvent prévenir toute forme de discrimination et engendrer des inégalités au sein de la société. Nous avons aussi mis en place depuis 2019, mais c'est dans ISDA que nos CAJAC, que nous appelons Advocacy and Legal Advice Centers, qui travaillent d'arrache-pied en collectant les doléances auprès des citoyens qui sont victimes ou qui ont été témoins de corruption durant leur accès aux soins. Donc, ces CAJAC nous aident en fait, dans l'approche auprès de ces communautés. Ils sensibilisent, ils discutent, ils peuvent comment dire, il crée des dialogues et crée un climat de confiance pour que ces citoyens, surtout ces femmes, osent hausser la voix et aussi, comment dire, euh, vraiment de demander des comptes au personnel de santé ou aux autorités locales. Donc, durant le projet ISDA, nous avons collecté plein de doléances aux environs de 2000, mais cet exemple dans ce slide, c'est juste pour la quatrième année, qui était pour 2025. Dans 75% des 13 cas sont rapportés par les femmes et 25% d'entre eux ont été résolus par les autorités grâce à l'existence de ces CAJAC qui osent discuter, qui font des plaidoyers auprès des autorités locales. Donc, je continue. Pourquoi, pourquoi nous nous sommes focalisés principalement sur les femmes? Donc, Tia Madagascar se focalise sur ce groupe, en fait, concrètement, parce que ce sont elles qui se trouvent en première ligne lorsque le système de santé ne fonctionne pas très bien. Ce sont elles qui viennent pour les consultations prénatales, qui accouchent, qui font vacciner leurs enfants, qui accompagnent les membres de leur famille au centre de santé. Et lorsqu'un paiement informel est exigé, donc une forme de corruption apparaît. Lorsqu'un médicament qui est censé gratuit ou un offre de soins qui est censé gratuit n'est plus disponible, c'est souvent elles qui doivent trouver l'argent, négocier et même voir s'endetter ou renoncer à l'accès aux soins. Donc, nos recherches ont montré une réalité simple, mais qui est vraiment assez dure à avaler, si je peux dire. Par exemple, lors des accouchements, qui sont des services censés être gratuits, comme je l'ai dit auparavant, des frais illégaux sont encore demandés. Cela place certaines mères en fait en face des choix impossibles, soit payer pour accoucher en sécurité ou bien préserver le peu de ressources qui est destiné à la nourriture et à la consommation de leur famille. Donc, derrière le mot corruption, il y a donc des visages aussi, des inquiétudes, des dettes, parfois des drames silencieux. Euh, Nous avons aussi, à un certain moment, aussi décidé de parler d'une réalité dont on ne parle presque jamais à Madagascar, qui est la sextortion, c'est-à-dire la corruption sexuelle. Lorsque l'accès à ces services dépend d'une pression ou d'une faveur sexuelle, il ne s'agit pas seulement de corruption de notre point de vue, mais d'une atteinte profonde à la dignité et à l'intégrité de ces femmes. Donc, nous essayons de briser ce silence, et briser ce silence est essentiel en offrant des espaces sûrs, comme l'existence de nos KAJAK. Ces espaces sûrs permettent à ces femmes de signaler et aussi nos KAJAK peuvent les accompagner juridiquement où nous affirmons ce que ces abus ne sont ni normaux, ni acceptables, ni inévitables. Donc, je termine ma présentation sur ce petit, je dirais, petit message à travers le programme ISDA. Nous ne luttons pas seulement contre des chiffres, nous ne luttons pas seulement contre des affirmations, mais contre un système qui oblige une mère, une famille à choisir entre vraiment, vraiment de nourrir sa famille ou de payer un pot de vin où elle trime, où elle a des difficultés à trouver l'argent pour payer ce pot de vin. Donc, ou bien, je veux dire, trouver, à payer un pot de vin pour accoucher en sécurité. Donc, l'existence de nos ALAC est vraiment primordiale parce qu'ils sont là pour dire que ce n'est pas une fatalité, mais l'accès aux soins devrait être pour tous. Donc, je termine ma présentation sur ces quelques points. Merci beaucoup.
Merci Gérald pour l'impact partagé avec nous et pour les témoignages euh, que nous avons constatés pendant ce projet. I now have the pleasure of introducing Kathy Thompson, who is co-chair of GRAND, the Grandmothers Advocacy Network, a partner that we're really excited to have here with us to moderate the next parts of the discussion. Kathy, over to you, and thanks for being here.
Thank you very much. I'm really pleased to be here too. I'm very happy to be part of the session and also to welcome this our esteemed panelists. I'm not going to read their complete bios, but if you have a chance, if you haven't read them yet, have a look at them. It's pretty impressive the things that they are and have done. So welcome to Mark Brender, who's the National Director of Partners in Health Canada, Danny Glenwright, CEO and President of Save the Children Canada, and Zora Bano, Regional Gender Advisor Asia with the Aga Khan Foundation. And welcome back to Gérard as well, who will be part of the panel. So, welcome everyone, bienvenue. And the first question that we're going to pose to our panelists is, from your field experience, what are the barriers preventing women and girls' access to health services? Is the barrier to access at the individual community or institutional level? Is it at the structural level? And if so, what are the enabling conditions that increase barriers to access? So if I could ask Mark, if you could begin, please.
Sure. Thanks, Kathy. And I just want to say a huge thank you to TI, to CanWaCH, and all the organizers. And thanks, Gerald, for that informative presentation on the work. I think there are many barriers, obviously, to why it's difficult to access services. But I'm going to focus on one being right at the start, weak health systems. And so in many places of the world, there's about 50% of the world doesn't have access to quality basic primary care. And the overwhelming majority of the people that don't have access is in the global south. And so we can ask, why do we have that circumstance? It's kind of a framing for discussions around lack of access and even corruption. I'm going to start with one story. We had Partners Health Canada, or Partners in Health, one of the co-founders of Phil Yadal has often said that, the hardest thing that we do is work very closely hand in hand with governments. And the most important thing we do is work hand in hand with governments. From a high level, I think, NGOs are not responsible for delivering rights for people. Governments are responsible for delivering rights. And the governments that we work with, and all organizations, I think, work to support, have signed, there are many UN declarations and treaties that they have obligations to deliver for their citizens, including maternal and child health, and many services accessed by women and girls. We had a Global Affairs Canada funded project, wonderful shout out to our Global Affairs Canada colleagues in Sierra Leone and Malawi. And a quick story from a couple years ago, there was a steering committee meeting and we were talking about successes and failures. And an official from the ministry said, and this was a very open, we've been working together for a while. And he said, let's be honest, we all know that outside the capital, this is in Sierra Leone or Freetown, the vast majority of nurses in the country are volunteers. And for people that aren't familiar, really on the ground, and if you aren't embedded in those health systems, it seems crazy, right? In Canada, the notion of a nurse volunteering is ridiculous. And yet, so to go back really at a high level, why would a nurse volunteer? Well, there's all reasons why governments don't have the fiscal room. If you look at the per capita healthcare budget per person from a government, so not including aid, in a government like Sierra Leone or Malawi, it might be $20 US per person per year that the government is spending on health. And African governments often get criticized for not spending enough. There's a target of 15%. Let's say they're at 7% and they double it. Okay, so we're at $40 per person. Canada is close to $5,000 US per person. So hundreds and hundreds and hundreds of times more resources that we have than a national ministry of health has, which leads to situations where nurses are having to volunteer, which leads to situations in the hopes of 2 years down the road actually getting on a Ministry of Health payroll. And then it leads to situations where they are forced to charge patients at the bedside for their own, to have any hope of income. And so that dynamic, we could call it corruption. We could also call it the result of colonialism that didn't build infrastructure, that extracted resources, that didn't provide healthcare services, add on to structural adjustment policies that both limit, constrain the ability of ministries of health to be able to hire more health workers at the same time when global north countries are incentivizing many health workers to leave and to come. And so I think that framing of the context in which the work actually happens is really, really important as we dive into some of the issues around how to improve access and work with health systems to be able to drive really positive changes.
Great, thanks very much, Mark. And let's go on to Danny, please.
Sure, thanks. First of all, let me say, as Mark did, it's so nice to be here, and also that I agree with so much of what Mark said. So I'll try to complement it with some specific examples. Um, I think when we think about individual barriers, Kathy, we're really thinking about awareness of existing services. Because so many of these services are not known by communities, by those that they're meant to serve, it makes it really challenging. We have a project in Egypt where we found that only 2% of the female and male youth had heard of the services that were being provided. Mark spoke about Sierra Leone, a country I know and love, and similarly there, services are really hard for many to access because there's low literacy rates and there's a high a number of disabled people. And in both cases, it's really hard to even be aware of services because they can't read about them. They may not be able to hear about them. And so that's a big barrier for women and girls in many countries. The other one is financial. It's often quite difficult to get to pay for transport to access these services. As Mark said, often clinics, facilities are charging for services even though they are meant to be offered free. And like Mark said, I may not call that corruption. It's just because the people providing them are volunteering. Increasingly, also, we are worried about, excuse me, a lack of agency. As we are seeing globally a backlash against the rights of women and girls, we are seeing that they have less autonomy over decisions that impact their bodies, and that impacts their ability to take decisions about these services. Moving to the community level, I'm thinking about, again, mobility. Unmarried women in Egypt, in the same project I mentioned, women and girls need to be accompanied by a male guardian when they're accessing services. We see in countries like Mali and Niger, where we work on a big Global Affairs Canada funded SRHR project, excuse me, that there's cultural taboos and stigma around adolescent sexuality, and these deter girls from accessing these services as well. At the system level, at the institutional level, something I've seen over, decades working in more than 20 countries in Africa is that there are negative attitudes from healthcare providers as well around SRHR services, particularly when it comes to adolescents, connecting these services to promiscuity. And that makes it problematic because women and girls often face abuse when they try to access these services. They often feel that the services won't be provided confidentially. In small communities, that matters. And the other one, as we've seen cuts to funding for programs like this, is the availability of things like contraceptives, of birth control pills, etc. And local facilities being less equipped means women and girls have to travel further, which often means they don't take the choice to do so for many of the reasons that I've shared. Expensive transport, they don't have time, they don't have the resources to be able to make those trips. At the structural level, I think workforce challenges and shortages is a big problem, as Mark has pointed out. It's a problem here in Canada too, but the level of the problem is much greater, especially in places where women and girls want to see female healthcare providers, and they often don't exist in many places. Again, I think of a context like Mali or Niger, where there's ongoing conflict, and often SRHR services are deprioritized in favor of providing humanitarian support, emergency support, and so we often just see these services cut altogether, as we did in many, many more places during COVID. And then at the structural level, we talked about the link to corruption. I agree with Mark. I don't know if this is corruption so much as it's health service providers are not being paid. And so we see cases of healthcare staff charging for SRHR commodities. And we also see shortages, which means that a lot of the staff are going out and buying things like condoms themselves for their clients. And of course, then they are charging for them because they're filling supply chain gaps themselves. Likewise, when we think about nutrition, we see this often in many parts of Africa where we go and see plumpy nut, which is the high protein paste we use to treat malnutrition, for sale in local markets, because that's what healthcare centers need in order to be able to keep going. So those are just a few of the barriers at different levels that we've come across at Save the Children.
Okay, thank you. And Zora?
Thank you so much. Thank you, Mark and Danny, for highlighting those all important points. From our experience implementing global affairs, Canada's funded initiatives, including Foundations for Health and Empowerment, which is one of the biggest programs across Asia. And through the long-term commitment of our Han Development Network, we have learned that um, there's a bigger issue which is much more greater than the individual community. For example, we have learned that a fundamental lesson, barriers to women's and girls' access to health services, they are not isolated obstacles. They are primarily systemic, they are layered and mutually reinforcing. For example, if we are serious about equitable access, we always have seen this and have unpacked and tried our level best through our initiatives to address it as well. And it's important for us that we understand the full ecosystem of the barriers in terms of how women and girls have access to health services. I won't repeat a lot of the issues which Danny and Mark have already talked about. Some of them are very much relevant to Asia as well, where we do have a lot of geopolitical issues and we do have context-specific issues as well. These issues range from financial constraints to decision making, lack of agency, and even a lot of them are unable to afford their transport as well. Another major issue, which is a very individual issue across Asia, is that adolescent girls who often lack access to safe information and accurate information about sexual and reproductive health. So, in our context, women they still require permission to seek care. For them, seeking care is the biggest entry point for to avail the facilities which are available within the ambit of the health services in their context. Similarly, when we talk about the community level, and that's how we have been working at multiple layers, that in our context across Asia, social norms, they act very invisibly. Social norms are basically the invisible gatekeepers for us. The harmful gender norms, they not only restrict decision making, but a lot of health issues are being stigmatized across our geographies as well. For example, mental health is one of the stigmatized issue. Gender-based violence and domestic violence, it's always a personal issue, a domestic issue to talk about. We have never spoken across our geographies around gender-based violence, whereas it's a public health issue. So another major issue, which is the community issue in our case, is early marriages, which does not only interrupt the education, but also it interrupts the health-seeking behaviors among boys and girls as well. So hence, how the discrimination for us is normalized in our context when there is a lot of systemic exclusion. Similarly, while moving ahead from the individual to community, when we talk of the institutional level issues and barriers, we do have a lot of issues which are beyond behaviors. Those are basically, the under-resourced facilities that we do have across our geographies. There are shortages of trained female providers. We do have weak referral systems, and we do have limited privacy and inconsistent quality standards. So, coupled with the conservatism that we do have across our geographies, distance, terrain, geopolitical issues, and fragility, a lot of these issues are life-threatening when they are not being dealt or prevented timely, or preventable conditions are available here. Lastly, I would touch base on some of the issues which are very pertinent and which are very unique to our context across Asia, that we lack adequate gender and age-specific disaggregated data, because we really feel like governance systems are fragile, and a lot of data should be used, and it should be used as evidence to strengthen our governance systems as well. Digital exclusion, it exists and persists across our geographies, which is not only deepening the poverty, but it's also expanding the existing disparities in terms of how women and girls have access to information about their health, how they have been educated about the health issues, and how they could reach out to, benefit from the available health services and resources. So therefore, gender disparity across Asia in the health sector is more than a service gap. It is a gap of power, and it is a gap of systems as well. So thank you. These are some of the points from our context. Thank you, Kathy.
Oh, I just realized I was muted. Thank you very much, Zora. And we'll go on to Giral.
Oui, merci beaucoup de m'avoir donné la parole. Désolé parce que je m'exprime tout le temps en français. Je m'exprime mieux en français. D'accord. Je pense que les trois panélistes ont déjà bien souligné le problème. En fait, on retrouve ces mêmes problèmes à Madagascar, même au niveau individuel, qui sont presque des contraintes économiques, en fait, qui sont liées aux contraintes économiques. Parce qu'une grande partie du financement, comme vous le savez, dans le système malgache, repose pleinement sur les paiements indirects des ménages malgré l'existence d'une loi sur les exemptions de certains paiements qui rendent les services gratuits. Donc, même lorsque ces services sont officiellement gratuits, les femmes doivent souvent payer des frais informels pour accéder aux soins, donc notamment lors des consultations prénatales ou des accouchements. Et pour des ménages déjà vulnérables, ces coûts peuvent en fait conduire à retarder, par exemple, leur prise en charge, ou bien qui les forcent à renoncer aux soins. Donc, et d'autres obstacles aussi peuvent émerger qui sont plus liés à l'information et au pouvoir de décision. Donc, dans certaines situations, les femmes ne disposent pas toujours de l'autonomie nécessaire pour décider de se rendre dans un centre de santé ou bien pour mobiliser les ressources nécessaires parce que, par exemple, elles doivent demander l'autorisation à leur mari ou bien demander l'autorisation à leur famille pour emmener soit leur enfant ou bien se rendre dans un centre de santé de base. Euh, Au niveau communautaire, en fait, j'aimerais souligner l'existence des normes sociales que je pense on ne parle pas souvent parce que ces normes je pense, jouent un rôle important dans la société. Parce que dans certaines communautés, les attentes sociales, en fait, peuvent limiter la mobilité des femmes voire même influencer leurs décisions en matière de santé. Par exemple, la priorité donnée aux dépenses de ménage peut ne pas favoriser, par exemple, la santé reproductive ou bien la santé préventive. Donc, nos recherches et nos observations pour les barrières au niveau communautaire ont montré également que la peur de l'humiliation ou bien la peur du mauvais accueil ou de pratiques abusives peuvent décourager ces femmes, ces filles et ces groupes vulnérables de se rendre dans ces structures de santé. Dans certains cas, des formes de corruption ou d'abus de pouvoir sont entretenues par ces normes sociales et peuvent créer un climat de méfiance entre la communauté et surtout les prestataires de santé. Et pour finir, au niveau institutionnel, ça a aussi été déjà souligné par les trois panélistes qui l'ont bien développé. Plusieurs facteurs peuvent limiter l'accès effectif à ces services de santé pour Madagascar. Par exemple, les infrastructures qui sont parfois délabrées ou bien éloignées des ménages, le personnel de santé limité ou bien qui manque d'expérience, surtout dans les zones rurales, et aussi les ressources matérielles qui peuvent manquer. Ça, ce sont des énormes barrières, en fait, qui limitent l'accès aux femmes et qui peuvent aussi entretenir le paiement de certains de frais informels. Donc, dans ce contexte, je pense que les paiements informels deviennent une pratique assez fréquente ici à Madagascar où les patients peuvent être contraints de payer pour des services gratuits, pour accélérer, par exemple, l'accès à une consultation ou pour obtenir certains médicaments au détriment d'autres patients. Ces pratiques constituent une forme de corruption qui peuvent affecter de manière disproportionnée les femmes. De mon avis, elles sont les principales utilisatrices des services de santé primaires pour, par exemple, les maternités, comme je l'ai souligné auparavant, les suivis prénatals, les vaccins de leurs enfants. Euh, et pour conclure, en fait, TIE Madagascar met aussi en évidence une certaine forme particulière grave, que nous jugeons grave, en fait, et souvent invisible de la corruption qui est le sextortion, c'est-à-dire que l'exigence de faveur sexuelle en échange d'un service public. Donc, l'ensemble de ces facteurs pousse la plupart des femmes à ne pas se rendre au centre de santé de base, mais choisissent d'autres alternatives, par exemple la médecine traditionnelle ou même voire le refus de soins catégorique. Merci.
Thank you. So it's interesting that you've shown us that the problems are similar, but such a unique context in different
Kathy,
areas
you're
of the
muted.
world.
No,
I'm not.
she's on.
I can hear
Oh,
you.
I
I'm
am
Just
on.
muted.
a,
My apologies.
Oh, that's okay. All right. So anyway, let's go on to the next question. And I'd like to ask each of you if you could share a concrete example with us from your work where addressing those barriers, including improving transparency or accountability mechanisms, has positively impacted health access for women, girls, or marginalized communities, and what made that change possible. So maybe we could start with Danny this time.
Sure. I was thinking about this and looking at some of the solutions for us and thinking, sometimes we overcomplicate things in our sector, in life in finding solutions when really it comes down to basic things. Think about being healthy in general, right? It's about eating well, exercise, and sleeping, and everything else is just additional to that. And so I think, but you can't do one of those things and be healthy. You need to do all three. And so, when I was thinking about addressing some of the barriers we're talking about, it really for me comes down to education, engagement, and collaboration across communities and advocacy. And those three things have to happen in tandem and simultaneously. An example for us is our foundations project. It's our largest SRHR project in Mali, Sierra Leone, and Niger. And I go back to the individual level. So there it's about the education piece. It's about strengthening adolescents' knowledge of SRHR and their rights to accessing those services. And we do that by providing comprehensive sexuality education. We also do that really through a really cool program where we do facility exchange visits. So we bring adolescents to SRHR facilities. And that allows them to meet the providers. It allows the providers to see them, to see who their clients should be. And it breaks down some of those barriers I mentioned. Providers are less likely to be charging unofficial fees when adolescents arrive. And it boosts the confidence of young people to be able to use those services and seek care at them. At the community level, this is the piece on engagement and collaboration and conversation. So it's bringing in those key interest holders in communities, whether it's faith leaders, religious leaders, traditional leaders, men and boys, and making sure that everybody's involved in a conversation about the importance of this and engaged in building plans around it to address the barriers that we've all mentioned in communities. At the institutional level, it's about providing training for healthcare workers and making sure they understand what the ethical standards are around providing services to youth, providing youth-friendly care, and to the rights of their clients. And we also encourage adolescents to be involved in committees and on task forces that exist. There's no reason why adolescents can't sit in these groups. And I'll give an example from Sierra Leone. We have an amazing young girl, a 15-year-old girl named Messi. She's working at community level, and she previously had been restricted from accessing some of these services by her family. But our team identified her as somebody who was really keen, and now she's sitting on a committee where she's working with adults to address some of the barriers, to address some of the harmful practices in her community. And she's now leading other children and adolescents in dialogues and mobilizing them and building awareness in her community. And I think it's really critical to involve adolescents in discussions at that level. And then the last critical piece is advocacy. So at the community level and the policy level, we really need to be advocating for the importance of women and girls' rights and making sure that policies address that as well. And so I think these interventions all need to happen together. The three things are critical and they need to happen simultaneously. And that doesn't matter if we're talking about Madagascar, if we're talking about Sierra Leone, if we're talking about Canada. It's critical that we're educating people, that we're building that engagement across different communities, and that we continue to advocate for the importance of these rights as economic pressures sometimes have stakeholders thinking about cutting these services. We need to continue that advocacy piece. Thanks.
Great, thank you. And Zora?
For us, thank you so much, Danny. A concrete example that comes from our gender integrated work through Foundations for Health, funded by Global Affairs Canada. It's also based upon our learnings across different geographies where Acadian is working, including Afghanistan, that a single intervention really does not work out for us. We have had the holistic approaches for different interventions. And similarly, for the same project, which is Foundations for
Oopsie.
Health and Empowerment, we had the holistic approach that enabled us to address a lot of barriers. So we recognize from the very onset of the project, which is Foundations for Health and Empowerment, that barriers to equitable access were not only about infrastructure or distance, but they are primarily around bigger and much broader governance issues, the responsiveness, inclusivity, and the voices that primarily help us shaping the services. So what we did was we embed mutual accountability mechanisms, which were directly and indirectly feeding into the services, into the planning processes, delivery and monitoring mechanisms of each stakeholder within the project as well. So firstly, how we did is based upon our learnings, and one of the success models is that we institutionalized structured community feedback mechanisms where women and girls are not coming as passive recipients, but these women and girls became active assessors of different health interventions such as maternal health, mental health, child health, and a lot of interventions around adolescents' health and well-being as well. So through formal platforms and semi-formal platforms that helped primarily those helped us to identify and address barriers and also to be part of the overall mechanisms which are around the overall management and governance systems as well. So this approach, it helped us to launch informal complaint mechanisms, and we were able to also help out to address those complaints as well. Another major concrete example for us from the same intervention, from the same bigger program, is that we do have community, besides community feedback mechanisms, we do have disaggregated data. We do have internal mechanisms, and also those data management systems are also available and accessible to our partners, which we use on daily basis, on our need basis as well, to strengthen and adapt our programs as well. For example, we do not go with the same interventions across different geographies. Let's say in Pakistan, if we do have something to work on the accessibility, affordability, and availability of health services for girls and women, the same intervention approach might not work for another geography or another province in Pakistan. Similarly, the interventions we had primarily for Afghanistan were primarily different from the interventions we designed for Tajikistan, Kyrgyzstan, Afghanistan, or Pakistan. So what we did was we were completely contextually relevant and culturally acceptable mechanisms, which enabled us to navigate the issues and work around the social fabric and gender barriers across different geographies as well. One of the successes that I'm going to be sharing as part of our end-line assessment of the project, which is around accountability mechanisms as well. For example, in Kyrgyzstan, over 5 years of project, the GPI scores reached 62%. In Pakistan and Tajikistan, they reached 62.5%, with some areas rising to 66.7%. So these gains reflect earlier the care-seeking behavior, improved, responsiveness, and greater inclusion of marginalized groups, including and primarily girls and women from these geographies as well. So for us, the key lesson is that equitable access is only possible when we do have mutual accountability mechanisms, not only the accountability of the government, state, and the line ministries and departments, but also the partners that we worked with at different tiers across the partnerships, civil society who are part of our bigger initiatives, the community itself, and Acadian institutions who are directly implementing the programs itself as well. Thank you.
Thank you. And let's see, we go on to Giral.
Merci beaucoup. Du point de vue de l'expérience de Madagascar, surtout de Transparency International Madagascar, euh, nous travaillons sur trois principales activités qui sont vraiment de comme disait Dani, l'importance de l'éducation. C'est de dire de l'éducation de la femme, de la communauté en général, comment les informer sur leurs droits, sur les services qui sont censés être gratuits. Euh, les conscientiser aussi sur l'importance du fait que ils ont une place importante dans le développement du système de santé parce que ce sont elles qui sont les premières à aller dans les centres de santé de base par rapport aux hommes, si on regarde la statistique nationale malgache, parce que 80% des femmes sont les principaux usagers de ces centres de santé de base. Donc, un second action aussi, c'est de conscientiser les centres de santé de base, surtout les personnels de santé sur l'importance de rendre les coûts de services plus transparents et de permettre aux usagers d'avoir accès à ces informations dans un langage compréhensible et adapté à leur communauté et aussi rendre ces informations plus inclusives, c'est-à-dire il y a des personnes, des individus analphabètes qui ne savent ni lire ni écrire et qui ont des difficultés à comprendre les affichages. Donc, on tente de les conscientiser, à nous aider aussi à informer la population de manière plus adaptée au contexte. Je trouve que je pense que le plus innovant que nous ayons fait à Madagascar ici, c'est la mise en place de ces ALAC, parce que ces ALAC sont un intermédiaire incontournable entre la communauté et les autorités, surtout les personnels de santé, parce que eux, qui sont des personnes provenant de ces mêmes communautés, sont capables de comprendre le contexte, comprendre ce que vivent soit les personnels de santé dans ces régions, comprendre ce que vivent les communautés dans ces régions et construire toujours un dialogue qui tente à renforcer la confiance entre les deux acteurs, en fait. Donc, ils organisent souvent des dialogues communautaires incluant ces agents de santé, incluant les autorités et incluant les leaders communautaires qui sont les plus écoutés, en fait, au sein de ces communautés. Pour Madagascar, ces actions euh, ont permis une meilleure information des femmes sur leurs droits, à réduire certaines formes de coûts informels dans ces centres de santé de base, et aussi, comme j'ai dit tout à l'heure, à restaurer un certain climat de confiance entre la communauté et les centres de santé. C'est vrai qu'il est difficile de changer le comportement de la communauté vis-à-vis des pratiques quotidiennes qu'ils vivent depuis toujours. Mais je pense que l'éducation et l'information se fait graduellement et dans un langage que eux aussi peuvent comprendre. Donc, ce qui a rendu le changement possible, trois éléments que je retiens essentiellement, c'est l'implication de la communauté. Ils se sont beaucoup engagés, en fait, et actuellement, nous voyons que les femmes osent maintenant hausser la voix et dénoncer toute forme d'abus, signaler les abus à travers l'existence de ces ALAC. Aussi, la transparence des coûts et l'accès à l'information, où certains centres de santé de base ont déjà fait des efforts pour communiquer tous les services qui sont gratuits ou non au sein de leur établissement. Et aussi, nous essayons actuellement de travailler en fait avec les autorités à travailler ensemble pour créer en fait un mécanisme qui permettrait aux citoyens de signaler certaines formes d'abus que font les personnels de santé ou certaines autorités sanitaires dans leur communauté, en toute sécurité, si je puis dire. Merci.
Merci, Gérald. And Mark?
Yeah, thanks. I just want to build on, I think that Gerald and Danny and Zora all touched on was this notion of community involvement and women and girls informing service delivery that's critically important. I think, we often hear from women and girls and adolescents about, I guess higher level, sometimes it's very common to blame patients for their inability to access services, right? We say it's a patient's fault, they don't show up, or they don't want care, or they don't trust, when they actually know very, very well what happens when they go to a health center or a hospital. And the existing circumstances determine whether or not that they will utilize services. So when we ask women and girls what they need, and they say, I need a confidential space if I'm going to access SRHR or talk about family planning, and yet when I go there, there's only a male guard at the health center, and there's one entrance, and there's no private space, and the room they take me in, everybody in the whole health center can hear what I'm talking about, and there's only a male nurse on staff. So all those things will contribute to the 16-year-old girl not even showing up, because she knows that when she goes there, that's the circumstance. There are solutions to all those things, right? They involve training of health professionals for sure, but they also involve construction of rooms or facilities or another entrance where there can be safe spaces, dignified, that they can actually access care in a way that will lead to positive outcomes. And so we need to think about kind of how global aid development funders are supporting country and locally led plans that say this is what we need. And if that's what we need, then we have to find a way to fund those kind of initiatives as what it means to strengthen health systems. There's nothing more dispiriting for a community or a population to be asked, what do you need? How can we improve services? And then nothing happens. And that will increase lack of trust in the health system. So I think that bringing together how our aid and government budgets are done to support what women and girls are actually saying they need is super important. I think from a structural level, and building on what Zora said about data, which is so important. Often, even building the systems that can collect data is just as important as the programs to prove proof of concept. We did some work on gender-based violence in Malawi, and as part of it, and we've all heard stories how different countries, different communities will say, we don't have a problem with gender-based violence. We don't have a problem with maternal mortality. No, all our women deliver in facilities, because the data isn't being collected to show, and that's through no fault of anyone local. It's that the systems haven't been put in place in this environment of scarcity again to allow that to happen. So when we were able to do some concentrated work with the community on gender-based violence in a place where they had never collected data on GBV before, this is very, very common. But as soon as you start to train health professionals, you have some resources, you start to build a register to collect data, then that accountability really will go through the roof, because practitioners now have a responsibility as part of their job to be recording what they're seeing. And there's a program that is actually asking women and girls in a safe way, so you can get accurate data, what's happening. Some of the work that we did in Malawi, again, over many years, resulted in this GBV register that, because of a very close, long-term, open-ended working relationship with both the local district and Ministry of Health nationally, the Ministry of Health scaled that GBV register nationally across every district in the country. And so for the first time, you had health centers and heads of health centers and nurses and clinicians being forced to fill out a register. And then everybody will know, if you have zeros across the board, that health center isn't accurately collecting, or it doesn't have a facilitating environment to get the proper data around the burden of gender-based violence. And so the accountability that comes through strengthening a health system, as opposed to putting blame on individual practitioners for their inability to set something up on their own, I think is something that we need to always keep in mind. One third really quick point is, if we say that there's a lack of capacity, be it locally, be it nationally, then when we're coming in with resources, how do we increase that capacity? At Partners in Health, we often embed people within ministries of health, because they need help in developing policy. They need help in applying for funding grants that will then benefit women and girls. And how do you have the capacity to really analyze the data that's coming in? We know that ministries are desperately short of the kinds of people that are needed to do that work. So if we say we're actually going to follow country-led priorities, which is where we need to be going, but all our organizations need to be thinking about how do we directly support ministries and governments to be able to have the capacity to deliver the services for their people.
Right. Thank you, Mark. As always happens with these events, we end up with less time than we thought, or things go a little longer than we thought. So we do want to have some time to allow people to ask questions. So we're going to move on to our last question. And what we'd like to do is ask you, each of you, if you could suggest one single well-organized priority that could be recommended for funders, government, Canadian CSOs, and development partners, what would it be? And I just wanted to say that GRAN is purely an advocacy organization, and I think what we're hearing is that advocacy is more important than ever. And I just wanted to mention that one thing we've found in the last few years is how important it is to work together and have one well-organized message that goes out from everyone. And just the fact of working in a coalition so that the voices are all giving the same message and are united makes such a huge difference. So if you could each of you just give us one priority to recommend, that would be great. So let's go to Gérald.
D'accord. Merci beaucoup. En fait, je parle toujours de l'expérience que nous vivons à Madagascar. En fait, ce qui empêche une excellente qualité de soins pour ces femmes, c'est vraiment lié aux lacunes de gouvernance et aux contraintes structurelles plus profondes que nous avons observées depuis ces années où Transparency International a travaillé dans le secteur de l'éducation. Donc, pour ma part, je suis plus dans le fait que les partenaires techniques euh, devraient, si je peux le dire, devraient appuyer la société civile, surtout en les appuyant dans les plaidoyers comment dire, de faire passer certaines lois et de faire voter certaines lois pour mettre la pression sur sur l'État. Par exemple, prioriser en fait la pression sur le vote de la loi sur les lanceurs d'alerte qui permettrait en fait à certains citoyens, à certaines personnes de vraiment dénoncer les formes de corruption qui portent atteinte euh, euh, qui porte vraiment atteinte au bien-être de toute la population. De un, de deux, l'accès à l'information. Ça aussi, c'est un point primordial parce que actuellement, nous n'avons pas vraiment accès à certaines informations que nous jugeons primordiales pour formuler des recommandations, pour formuler un modèle qui permettrait de réformer le système de santé actuellement. Donc, euh, ce- la priorisation, en fait, c'est de vraiment mettre la pression sur le gouvernement pour qu'il puisse songer au fait qu'il y a des dysfonctionnements et qu'il faut vraiment ajuster certaines tirs. Un point aussi que je voudrais appuyer, c'est que euh, à Madagascar, on a vraiment comment dire, cette instabilité politique qui ne permet pas de faire évoluer les actions qui ont déjà porté ses fruits auparavant, parce que quand les autorités changent, le staff du ministère de la Santé change, les priorités changent, donc on reprend les actions à zéro. Donc, c'est cette continuité de l'État qu'il faut aussi qu'ils prennent en compte. Merci.
Thank you, Gérald. Now, just before we go on to the next person, I'd just like to ask anyone who might have a question if you could put it into the chat now so that once we've finished with our speakers, we can go right on to the questions. So, Danny, if you could continue, please.
Yeah, sure. Just to again a big times 2 to everything Gerald said because I agree, and also to build on Zora's very good points earlier about data. I think well, I'll use this moment to amplify a call from our partner in West Africa, the West African Feminist Network. And what they really need and what we really need to support them is that it's resources, financial, human, and technical to build transparent and accountable data systems that are well governed and that share data that we can use to be strategic in our decision making in collaboration. As we've all said, it's so critical to be collaborating, but also to hamper the corruption that we've talked about over the course of this hour. Strong data it will get at that. It will also address some of the challenges that I raised earlier around stigma in healthcare systems, right? I earlier watched a video from a healthcare worker that we worked with in Sierra Leone, and she talked about how she previously did have that stigma toward adolescents that were coming in for services. And then she saw the data around how adolescents were affected by some of these things. And she had training, and that helped her change her views, and it helped her be much more accepting in her work. So those three elements I talked about earlier, collaboration, engaging communities, advocacy, as you said, Kathy, and that strong data is really what we need right now to enhance our impact in this space, to get at the corruption we've talked about, and to make progress in this critical area. Thanks.
Great, thank you. And Zora?
Thank you so much, Danny. If I could suggest a single overarching priority for improving women's and girls' access to health services across Asia, including the complex communities and countries where we are operating, such as Afghanistan, it would be to strengthen and scale community-based women's health systems, which are led by locally trained female health workers. So this approach helps us to primarily, and it's a proven approach basically, to help address some of the most persistent barriers of accessibility, availability, and affordability in the region. So we have talked much about the financial constraints, and financial constraint is very linked with the decision making. They are interdependent. So we really feel as part of the academic interventions that the opportunity to work and scale community-based women's health systems is one of the priority areas for us. Linking to that, I would also suggest that for Canadian CSOs, they should continue to play a strong role in the capacity strengthening, not only capacity strengthening of the private sector in community advocates and community health workers, but also to build the capacity of civil society organizations which are in the stream of health services, so that we partner with them and we introduce and strengthen the localization models as well. So by working closely with the local organizations and women's organizations, we have seen that they can support training programs. They can also strengthen community engagement models. They can work very extensively and to an excellent level on the social and behavioral change models. And they can also advocate for the gender responsive health policies as well, because they are so much entrenched and closely linked to the local government systems that they really can work and advocate for the gender responsive health systems. So their partnership often helps to bridge the global funding gap and the priorities and the locally led solutions as well. So I really feel like, this could be one of the most overarching priority for us to think about and to navigate how do we work more to make these services more accessible, affordable, and available to women and girls.
Okay.
Thank you.
Okay, and Mark?
I'll keep it very quick. I think across the board, long-term relationships. I think this is from organizations, from funders, from civil society, and both for effectiveness of care delivery and strengthening health systems, but also for the trust that's needed to understand, if we're talking about corruption, that has a whole bunch of causes. And if we are to understand and address those, there's no way we're going to do it if we're starting to work somewhere because of a 3-year grant and that grant ends and then you're gone. And so communities know that, they have very good reasons for who they trust. And you will trust your own family. We will trust our friends and our networks who we have long-term relationships with. And I think it's the same in all the contexts where we're working. And so kudos to Global Affairs Canada, which has found ways of increasing the length of grants, which is critically important. And I say this knowing for what, and agreeing with Gerald in terms of the challenges of working with governments when there's constant change and constant flux. It is very, very, very hard. And yet, as Salvatore said at the beginning, how do we not use the weakness of governments, but to sometimes and health systems as excuses or rationales not to invest? Because we know that none of the things will be sustainable if we don't, over the long term, find ways of ensuring that ministries of health are capacitated and held accountable to deliver on their obligation to provide health for their people. So the long-term relationships are really key.
Yeah. Okay. Thank you very much. Thank you, all four of you. And you've given us lots of information, and I think you've really helped us understand the complexity of some of the problems. And now I'm going to ask if there's anyone who has any questions to ask any of the panelists, or any experiences that you might like to share.
Well, thank you. I'm actually the chair of TI Canada, and I wanted to first thank our panelists today for their really, I think, enlightening comments. And I also welcome the cooperation with other NGOs in Canada. I mean, many of you look at the systemic problems you're facing in the delivery of your programs, not necessarily as corruption, because you do point to a lot of some fundamental systemic problems. But TI generally, and TI Canada is an organization focused on corruption. And my question to you, and you've alluded to some of that, how can we help you work better, more effectively, while staying in our lane, so to speak? Because we're not a health delivery organization, but we want to make the kind of work you do more effective. So what are your views on how we should be helping you? And also in Canada, not just in the countries where you deliver, but in Canada, are there things that we can do with you? Thank you.
Jump in, Kathy. Thanks, Susan, and thanks for including us and all the work you do. I think it's, I go back to some of the points we made in this conversation, the importance of advocacy around some of these issues. Transparency International is so good when it comes to data and when it comes to advocacy on these issues. And so I think in that regard, keep doing that. And to Mark's point as well, I think it's about putting pressure on governments so that they are aware of their role in service delivery, is particularly around social issues and social change and health. I think that's a critical piece as well. And I think that more of that would be great. And continuing to collaborate as well. Also to Mark's point, building partnerships and relationships here in Canada and if possible in some of the countries where we jointly work. I think that type of collaboration and joint advocacy really, really helps. And so I would say more of that.
Okay, would anyone else like to add to that?
I'll just say, add to Danny's thanks. Susan, I guess just the only thing very quickly would be the more that we can also call out initiatives or frameworks that aren't working to support locally driven priorities gives us more credibility when we speak out against corruption. So if we're saying on the one hand that it is really important that priorities are driven locally, initiatives are driven locally, that ministries have the capacity to do what they need to do. If there's work that's not working in terms of those objectives, let's call it out. And then that gives us added ammunition, or at least respect and credibility to be calling out governments when they aren't performing on that obligation.
Anyone else? Okay, let's move on to the next person. I see that El Hadji, and I'm sorry if I'm not pronouncing your name correctly, but you have your hand raised.
You did it correctly. Thank you very much, Kathy. Thank you for the presenters for the interesting presentation. I'm El Hadji working with Plan International Canada. I will go in French. French is my first language. En fait, je voulais, merci Marc, Danny et Zora. En fait, mon problème, c'est que je travaille avec les projets du Fonds mondial qui ont également un peu le même mécanisme qu'on appelle le Community-Led Monitoring, qui travaille aussi, qui a un peu comme objectif l'accountability comme objectif derrière l'amélioration de la qualité des services et l'accessibilité à tout le monde. Maintenant, ce que j'ai remarqué dans les différents pays, parce que moi je viens du Sénégal, donc je connais bien le contexte de l'Afrique de l'Ouest, c'est qu'il y a une fragmentation des réponses. Voilà. Maintenant, et moi, ce que j'aurais suggéré, tout simplement, c'est que les pays, les partenaires aient ensemble pour des réponses beaucoup plus robustes et alignées. Mais cette fragmentation des réponses, un partenaire health arrive avec sa réponse, Plan international arrive avec sa réponse, le Global Fund arrive avec sa réponse, je ne pense pas que ça marchera de cette façon. Pour moi, il faut quelque chose de global, surtout que les systèmes communautaires sont encore très, très faibles. Il faut de gros investissements pour aider les communautés à bien comprendre. Parce que pour moi, comme vous l'avez dit, comme vous l'avez souligné, ce sont les communautés, les populations elles-mêmes qui sont au forefront de cette lutte-là contre la corruption dans les services de santé, qui a comme dégâts tout ce que vous avez cité tout à l'heure. Merci pour cette intéressante présentation.
Thank you very much, Alaji. Go back to Transparency International now for some closing remarks.
Alors, je vais commencer en français, juste en continuant avec le français après Monsieur El Hadji. Donc, aujourd'hui, nous avons entendu plusieurs témoignages qui nous ont éclairci la nature et le fond de la corruption partout quand il s'agit des services de santé publique. Et nous avons entendu que même si la corruption est toujours ou souvent traitée comme étant un problème un problème individu, un, un politicien corrompu, un individu corrompu, ou même une société entière corrompue, euh, c'est pas le cas. Nous avons entendu parler des services de santé qui manquent des ressources. Nous avons entendu parler du manque d'infirmières et médecins et médecines femmes. Nous avons entendu parler des standards de qualité peu consistants. Nous avons entendu parler aussi de l'effet de la corruption au niveau systémique, quand les infrastructures de santé sont affectées et impactées et minées par la corruption, ce qui a un impact majeur surtout sur les femmes et les filles. I'm pleased that then we started talking about solutions. Again, not just at individual level in terms of addressing the social norms that may exist around corruption and how we respond to it, particularly women and girls, but how at institutional and systemic level, things like access to information that is made inclusive for people who may be illiterate, increased information about people's rights vis-a-vis the healthcare system, enabling community involvement and participation in informing service delivery, construction of rooms and facilities that provide safe spaces, entrances and exits for women and girls particularly. What we heard is that all of this is essentially about restoring trust between citizens and governments, between communities and healthcare providers. And that's essentially why I think this project has been so revelatory for us, is because it really gets to the heart of what democracy is and what the social contract is. Through inclusion, through sensitivity to gender, and through a really nuanced understanding of corruption, we can arrive at a stronger social contract and a stronger accountability of the state to its citizens. Again, coming back to one of the first points made at the beginning of this webinar, NGOs are not responsible for delivering services that are a fundamental right. Governments are. And so we've heard the call for Transparency International in Canada and globally to help with assembling the data, to help with carrying out the advocacy. And that's a call that we're hoping to answer. C'est un appel auquel nous avons pu nous préparer aujourd'hui. Notre réponse, nous sommes prêts au TI Canada d'être votre partenaire et nous comptons continuer notre collaboration. Nous remercions tout le monde qui était présent ici aujourd'hui et je remercie tous nos partenaires qui ont participé et j'espère que c'est juste la première interaction que nous aurons et je vous remercie encore de votre participation et votre présence avec nous aujourd'hui et merci encore.
Thanks, everyone.
Thanks, everyone.
Thank you, everyone.
Thanks all.
Thank you so much.